Professor.
Hello.
Nice to meet you. How are you?
Good, thank you.
Take a seat. Well, welcome to our Red TV set. I would like to first ask you if you could just summarize the presentation that you are here to give.
Okay, so I had the privilege to present or summarize the recent European Society of Cardiology together with the European Atherosclerotic Society of Cardiology 2019 lipid guidelines that were released and published at the end of August this year. Basically, new defining cardiovascular risk. This brings two new targets and goals, only based on scientific evidence, and to help doctors, GPs, specialists, cardiologists, and others to bring more patients to these goals, to help them with new combination therapies for lipid lowering. Having said that, statin should always be the first line of treatment. Then adding, if needed, ezetimibe. And if still not at goal, the great help of the new PCSK9 inhibitors. New risk categories, new goals, and new modalities or combination therapy to help more patients to be at low lipids to reduce their cardiovascular future risk.
Fantastic. What would you say is the biggest challenge in patient management post-MI?
The biggest challenge is to try to advise them and to make patients aware. This is a daily challenge, that by reducing LDL without improving their quality of daily life, they will reduce a cardiovascular risk, and this is only achievable with drugs that will again not change their daily life, may induce some side effects, benign muscle pain or some, and this is to reduce a risk. It's clearly different that from if you have migraine or headache, you take a pill a day and you have less migraine or no migraine. We are challenged. This is the big challenge, and this is also true for high blood pressure, for diabetes, for cholesterol. These three cardiovascular, very well-known cardiovascular risk factors. You need to reduce blood pressure, you need to reduce sugar, glucose, and lipids. This will not, improve your daily life. It will reduce just a risk. But this is somehow fundamental to try to convince the patient that there is a need to reduce these cardiovascular risk factors if they are clearly present. This is a big challenge.
And last question, so taking into account the new guidelines that we already mentioned and the local Swiss limitatio for patients in secondary prevention, what have you changed in your daily clinical practices as a result of these two factors?
Obviously, the new guidelines will ask us to prescribe more lipid-lowering therapies. Again, statin first. There will not be more statin prescribed. There will be more addition of ezetimibe, yes. And you can call it a winner, but there will need more ezetimibe to reduce LDL to the goals. And if needed, there will be more patients that will need a beneficial effect of PCSK9. Now, in small Switzerland, we had a good news, I think a couple of weeks ago, 1st of October, that evolocumab, Repatha, at least for this one, now we are able to prescribe and to be reimbursed by all insurance companies if the patient is not under, if he or she is still above 2.6 millimole, which is 100 milligram deciliter, then for all the patients, whatever the risk, if he or she is above 2.6, 100 milligram deciliter, the insurance have to reimburse Repatha evolocumab. Right. So for us, I would say it's brings our life much easier. Before we had to do a lot of other things. There was the very high risk patient or the primary, secondary. Now it's clearly 2.6. I was hoping that this will be even lower to somehow protect even more patients. It may come. It possibly a money issue, or I don't see other reason, because safety is not an issue, but clearly it makes our life to prescribe Repatha evolocumab much easier now, yes.
Fantastic. Excellent. Well, thank you very much,
Thank
Professor.
you, thank you.
Enjoy
My
the rest
pleasure.
of the conference.
Thank you.